Welcome everybody to our weekly series, It's Worth a Shot from Mountain Pacific Quality Health. This is Kyla Newland, account manager and pharmacist, and I will be doing our opening today. We can go to the next slide, Mary. And then we're going to have a guest speaker from the Alaska Department of Health to talk about some updated hand hygiene for our main presentation. So just a couple new resources. I guess resources and updates that came out that we wanted to give everyone a heads up. We'll put these links in the chat. We did update our COVID-19 bivalent vaccine top 10 questions, given the changes that came out with the bivalent vaccine recommendation. So that's accessible on our website. And then we also have a couple of memos, 2 QSO memos and some recommendations for universal source control and admission testing in nursing homes that came out since we last met. And if you have questions on those, you can feel free to stick them in chat or address anybody at the Mountain Pacific team who might be your contact. We can go to the next slide. So I think we have a couple polling questions. Okay, the first one, do you feel like you have the resources to provide vaccine education to your residents? Yes or no?
We only have one polling question.
Just one? Okay, perfect. Well, it looks like we're getting really good results. We've got 100% saying yes, so that's awesome. Give it just another couple minutes here. Okay, we're still at 100%, so that's great news. Thank you, everybody, for participating. And then, as always, we continue to meet every Wednesday, and if you have ideas for topics or things that you want more information about, please shoot those our way, and we will try to put those on our agenda for future sessions. We can go to the next slide, Mary. So we presented a couple weeks ago when the CDC came out with their up-to-date recommendations for getting that second bivalent booster for some higher risk populations. So they have now updated their website, and you can access those recommendations via the Stay Up to Date link. And there's also a frequently asked questions. Basically, everyone age 6 and older, regardless of whether they've had a COVID vaccine, are recommended to get at least one dose of the updated bivalent booster. Patients age 65 and older may get a second dose. So this is not a should, but this is a may statement. And that also includes folks who are moderately or severely immunocompromised. So those folks should have a discussion with their healthcare provider to see if they are a candidate to get that second bivalent booster. And then for children, there's different recommendations based on how many doses of the primary series they got and also which primary series they received, either Pfizer or Moderna, because there is just a couple different variations in the recommendations there. And then the CDC vaccine recommendations, so like our vaccine schedules, will be updated as needed. Did I see a question in the chat, Miranda?
Yeah, it looks like for the polling question, sorry, it just popped up. It says, do you mean written resource or people comfortable speaking to the residents about vaccine? And then Lori answered and said both.
Oh, okay. Sounds good. Okay, we can go to the next slide. So this is our weekly COVID snapshot. As you can see, we're trending down in cases and hospitalizations, just a little uptick in deaths, and we're still holding pretty steady with our bivalent boosters, seeing a little bit of an increase in that as we go week to week. We can go to the next slide. And this will probably be the last week that we're seeing this, because as we understand it, the CDC is no longer going to be posting this information for the community transmission levels, which is really sad because we're not going to be able to see this data anymore. But here's where we're at for this week. And we can go to the next slide. So we did have questions on the kind of definition of up to date, which I think I addressed, but these address specifically just that up to date status. So to be considered up to date, if you're 6 and older, you just have to get 1 dose, basically. If you're 6 months to 5 years, you have to get certain doses for the primary series based on which vaccine you're getting, either Pfizer or Moderna. And then at least 1 updated vaccine dose. And then if you're a patient that can't get the Moderna or the Pfizer because you maybe have an allergy or you had a previous severe adverse reaction, you can be considered up to date when you get the Novavax series that's appropriate for your age. We can go to the next slide. So this was the group that was kind of singled out with that you may get a second bivalent booster dose. And for people 65 and older, you can get that, and you can have that conversation about whether you think that you're at higher risk with your provider, but you have to wait at least 4 months after your prior bivalent dose. And then for those folks that are immunocompromised, looking at how many doses they've gotten previously. And then the recommendation on that age group is to wait at least 2 months since your last bivalent. And that'll be based on looking at your history, but you may choose to get one if that decision is made that you might be at higher risk. Hopefully that makes sense. And we can go to the next slide. So without further ado, I will introduce Anna Frick from the Alaska Department of Health, and she's going to talk to us about some hand hygiene guidelines. Thank you so much for joining us today, Anna.
Hey everyone, I'm happy to be here, and we are going to go through an update to SHEA's compendium on hand hygiene. Could I go to the next slide, please? Right, so this document, if you want to hit next, and yeah, so SHEA, if you aren't familiar with them, that's the Society for Healthcare Epidemiology. They are very similar to APIC, but they tend to take up more of, they're like very, very research oriented. They worked with a bunch of partner organizations, including APIC, the Infectious Disease Society, the Joint Commission, sort of everyone you might expect to write this giant, they write a lot of giant compendiums on HAI related topics. They get lots of expert input. They're sort of this is like one of their core group functions as they write these big documents together. And this is their one on hand hygiene. They have a long section on methods, which you can read in the document if you want, but the sort of short version is that they do a lot of literature review. They get experts together and sort of make some consensus statements about what the literature says. Then they consider possible harms. And then they also they're all, people who work in the healthcare setting and care a lot about this being functional guidance that is appropriate to actually usable by healthcare providers in the field. Next slide, please. So the structure, the first item there is that there are sort of these 7 essential practices that each have a lot of sub-bulletins. They have 3 things you might consider in specific outbreak settings, and then they have a short list of do nots, which are sort of common misconceptions. They have also a section that talks about why hand hygiene is important, which is a helpful reference if you ever need to have evidence-based. If you can draw on that to say this is why this is important, here's some evidence, you can sort of just take SHEA's ideas about it. And then they have a long section as well on considerations for how you might measure hand hygiene adherence. Everything is in this document. It's totally worth your time to read through it. I would strongly recommend having a look through this. This is going to be a very brief run through because we've only got 20 minutes, and just wanted you to know what all is in there. As one final little note, the target audience is hospitals, but much of the content is applicable in sort of any healthcare setting. Next slide, please. Maybe a quick reminder at the top of the talk of when hand hygiene is recommended. So you should be cleaning your hands. There are many schema for when But, the WHO has these sort of 5 moments of hand hygiene. CDC has a package of indications, which are sort of highlighted here. In particular, when you sort of look through the literature and when you do observations in the field, you'll often find that moment 2 or any of the other, its close associate, the buddy of moving from dirty to clean, those mid-task kinds of hand hygiene moments are very commonly missed. Broadly speaking, the available data indicates that hand hygiene is probably lower than you think it should be. Next slide, please. So the first of the 7 essential practices is the idea of healthy hands, which is basically that if your hands are red, chapped, cracked, bleeding, your nails are in rough shape, that you hand hygiene you'll not have an easy time keeping your hands clean, and that you will be more likely to transmit and carry pathogens around. Also, there's sort of risks to you as a professional because you might have, exposed like cuts and things. So this recommendation was included in the old version of the compendium. They've added more data to support why it's important. They have made some minor tweaks to their comments about fingernails. As we'll see several times here, they recommend alcohol-based hand sanitizer over soap and water in most situations. There's a lot more details in the actual document. This particular essential practice I would highlight as a good option if you're hearing complaints from staff about not wanting to wash their hands because their hands are dry. This section has a lot of tips on how to help handle that, and also potentially would help you make a business case for why you should be able to provide like moisturizer or other resources to help support your providers in having healthy hands that are easy to clean. Next slide, please. Number 2 is products. So it's just to select appropriate products. This recommendation was included in the old version. They've also added some more data about it. I think one of the key points here is that it also offers you like a lot of great opportunities to do this stuff ahead of time, right? Like these are recommendations you can implement that don't require your staff to like be making game time decisions and sort of remembering to perform hand hygiene. These are all things you can do to help set them up for success. Bullet point C is maybe a little bit weird. I was looking at the studies they cite there, and I think sort of the moral of the story is that if you are seeing like sort of some shiny stuff about like, oh, we have a cool new product that like magically is super good against this bug, it's worth reviewing manufacturer product specific data. That's just what that's about. Next slide, please. So this is also a place where you can really set your staff up for success. This is all about like the workflow and sort of making sure that hand sanitizer dispensers are everywhere and it's easy to follow your recommendations for it. It's probably worth doing some observations of staff's workflow and making sure that the dispenser locations are in alignment with these suggestions. Obviously, you also have to consider life safety code with sanitizer dispenser locations. I think, the workflow point here is listed as having some limited evidence, but I think that if you sort of consider staff experience, you'll certainly see why that is sort of patently obviously important, even if there's not a ton of data. Sorry, I have a new foster puppy who's very confused about what her job is in this version. Right, so especially if like one of the reasons you're hearing from staff is that they don't have time to perform hand hygiene, I think leaning into the points of item 3 here is a good place for you to start figuring out how you can support that. All right, next slide. Practice number 4 is a new recommendation in this edition of the compendium, and that is their point about glove use. So training on doffing to prevent contamination is a new addition, and then they've sort of made more clear statements about not double gloving. So double gloving is not routinely recommended except in sort of limited situations, like for example, some of the Ebola recommendations. Subpoint B is one I also wanted to highlight, that it's just a reminder that whenever hand hygiene is indicated during episodes of care, providers should doff gloves and perform hand hygiene. That is also like a sort of commonly missed moment. Next slide. All right, next up is sinks, which is also a new recommendation. CDC has a lot of feelings about sinks and the water system in healthcare facilities right now. This is a a very hot topic for them. So it's worth, taking a good look through this. Point D, about reminding people not to dispose of everything down hand washing sinks. That one is worth paying attention to. There's a lot of data that sort of supports that if you do that, you will get the growth of biofilms, which is a good way to encourage antibiotic resistant infection outbreaks in your facility, which obviously we prefer to avoid. And then point F, about keeping things out of the splash zone. That's also a place where you see a lot of like workflows. A patient who's been with you for a long time can have just sort of piles of stuff stacked around the sink. And that's not ideal and is something that CDC would strongly recommend that you avoid. All right, next slide, please. Cool, so point 6 and point 7 kind of go together. Point 6 is to monitor adherence to hand hygiene. I definitely encourage you to read through this section as they have like a lot of interesting content here. One of the points that I feel like they sort of talk about indirectly, but I thought I'd mention is that the framing of this is really important. Obviously, everybody knows that they should perform hand hygiene, so it's really important to set up your monitoring conversation to ensure that it stays constructive and that you don't expect people, it's not going to come across as, promoting a defensive reaction. This is not a punishing thing. This is an empowering thing so that we can recognize, how we can do better and also what we're doing well. Let's see, next slide.
Question.
Oh, sure.
It says in LTCs, does the ABHR need to be mounted in mounted dispensers? Can't the bottles on top of PPE carts or treatment carts, which I'm guessing that's supposed we can't have, can't have bottles?
Yeah, so I think it's fine to have them. It's about locations, and you want to make sure that, right, as Lori said, it's okay if they aren't like sort of permanently attached to a surface, but you also want to make sure that they are getting filled, that they're not getting moved around, and that location actually works for the workflow. If the cart leaves the room, then is there a hand sanitizer dispenser available in the room? So it's all about the workflow component. Right, so can we go to the next slide? Awesome, and could you hit next so that my little table appears? Beautiful. So this is a table from the compendium that talks through all the different possible ways you could think about monitoring hand hygiene. I just wanted to sort of mention this, that there are a lot of options and there might be some new ideas for you here. They strongly recommend that you do at least 2 of these, right? If you're just doing one, you're probably missing stuff. And particularly if your current system is that someone from your infection prevention team just sort of lurks on a floor monitoring hand hygiene in and out of the room for like an hour a month, you're definitely missing a lot of things. So this is like a good chart to look at if you are trying to think about how you could grow this section. And then the next slide, please. And so the next one, let's see, is their recommendations about sort of like how you could, what data you could provide out as part of your monitoring process. And then next slide, please. All right, and so then this is the feedback slide. I consider this to be sort of a part 2 to the item number 6 about collecting data. Also you have to get that data back. If you could hit next. There's a specific like paired table to the thing we just talked about different ways you could measure, and that's recommendations about how you might provide that feedback back. So this is actually like a pretty fast cadence, I think, for a lot of these. They recommend that you are doing this like very quickly, that the feedback is sort of real time, which maybe it's because I live in public health, but that feels very fast to me. Their rationales for this section, as they sort of fully acknowledge that this is like one of their less data-driven ones. A lot of their data comes from a Cochrane review that you could look through. I didn't read the whole thing, but my takeaway was that there's not explicit data that says this is the right way to provide that feedback. So it's probably worth spending some time with staff at sort of different levels and different roles, thinking about how they would like to receive feedback. And then also, of course, considering who's doing your observations and what they're comfortable with. You know, if it is uncomfortable for your reporter to provide immediate feedback directly back to that person, then maybe that's not the right strategy for you. Next slide, please. So the additional outbreak recommendations, you'll notice that the evidence isn't sort of as good for these points, but they're here if you need them, particularly for point number 2. I think they're sort of imagining a situation where you have an outbreak of a water bug like Serratia or Pseudomonas, and you expect that that bug is sort of living in biofilms in your sink and then sort of splashing into the environment. If you find yourself in this situation, that is a great time to call me or your state HAI program. That's the kind of situation that we can potentially be pretty helpful in. Next slide. There's a sort of short naughty list here. This should all be pretty familiar, and I think we've talked about most of it as well, especially like the glove content. That's very explicitly called out in its own recommendation. Next slide. In the implementation strategy section, this is like a pretty long part of the compendium. There's far less conclusive evidence about what works best in the implementation realm. They have some recommendations that are based, I think, a lot on professional experience and on sort of a sort of wide assortment of like single and 2-off kind of studies. You can think about which of these things might work for you. I did want to highlight that the train and educate section is probably like an easy one that you could probably do better on, just because there's, I think, a lot of perception that everyone knows how to do hand hygiene. We can sort of like skim it. Yeah, you know, we have this requirement to do education on it once a year, but everybody already knows this. And I think the recommendations are pretty clear that you should take this seriously. You should use high quality educational methods like return demonstration, doing fun and creative things, and just sort of reminding everyone that this is fundamentally one of our most important methods for keeping ourselves and our patients safe. Next slide. All right, I figure we'll probably have some time for questions, but just sort of like some brief conclusion things. The first one is that you should just never stop working on hand hygiene. It's really important, and it is a thing that we just have to do. Next one is you should definitely read this document. It's super helpful. I would really encourage you to implement a lot of these recommendations. And then finally, just achieve inner zen about how this is a thing we always have to do. For hand hygiene is one of those things like vacuuming and brushing your teeth and eating vegetables. You just kind of have to do all the time. You don't get a marriage badge for like doing it one time and moving on. So it's just one of those things we have to keep at. The next slide is just a link to the compendium. So it's there for you to click. It is free. You can go through it. It's got lots of helpful tables like I showed you. Again, can't say enough nice things about this document. And I think it's time for questions.
Thanks, Anna. Does anybody want to come off mute and ask any questions?
Let's see. We had some more discussion about the safety concerns for, you know, do you have to have wall-mounted dispensers? There are a lot of pieces to this, and I don't have a I know like CMS has specific rules about how they want this done. Different other serving agencies also have opinions. And I actually haven't opened up the life safety code stuff to know what all the rules are. So obviously like follow more explicit rules and ASHRAE guidance and stuff like that. But in the end, all of this is part of like, you have to find a solution that works for your facility. They have some other comments in there about, you know, if you have residents who are likely to try to drink hand sanitizer, then there's some other comments about sort of how to handle that situation as well.
I will grab the link from Anna's last slide and put it into chat for everybody.
Oh yeah, here, I can copy that into the chat for you too.
Any other questions or any statements or anything anybody wants to talk about?
Hey, Miranda, it's Kyla. Thank you, Anna, so much for presenting for us today. I put in chat a little bit ago, something I forgot to mention when I was talking about the vaccine updates. The first RSV vaccine was actually approved last week. So that's really good news. It's going to be for 60 and older. And we just have to wait for the next ACIP meeting when they will basically the FDA approved the product, but they have to put their recommendation in. So I think that's going to be great. I think that's awesome news. It was very effective. It had minimal side effects as we've seen so far. They're actually going to go and study it for 2 more RSV seasons. So they'll have 3 seasons to see how it continues to, how efficacious it continues to be as we move from year to year. So yay.
And this is Lori. I would just tag on. I know Denise had questions and great answers there, Anna, with the placement of our alcohol-based hand rubs and the question on use of like things that might sit on a, a tabletop or in other places. So using those bottles. So I just want to encourage everyone to use risk assessments in your facilities for deciding how to and where to place in collaboration with IE or safety departments to make sure, of course, we have fire safety and all of those things. But if you're in a facility or a location, or let's say you have residents or you have patients, if you're in a certain facility that may have some dementia patients or maybe those with mental health challenges or other issues that you feel are at risk of misusing alcohol-based hand rub, then you may need to put that kind of an assessment in place as to how you can safely provide alcohol-based hand rub and keep those residents or staff or patients safe. So include that. That's been kind of a catch thing lately with surveyors as they're out. The Joint Commission addresses that too. They've gone to that whole stratifying thing. So consider that as you're working on your hand hygiene program and your policy. If you have concerns about that, putting in a risk assessment to evaluate those and describe how you're going to mitigate those risks would be appropriate.
I see we have another question in the chat about the NHSN definition of up-to-date and entering data. The question is, NHSN definition of up-to-date will change next quarter. How do we enter a resident or staff member who only got 1 bivalent vaccine until the definition in NHSN changes?
That's a great question. The current definition is one, I like to call it one and done. If in general, for most people, if you have 1 bivalent vaccine, you are considered up to date. That definition in NHSN is going to stand for at least the next quarter. And so we'll see what's coming down the pipeline after that. If we have updates, now we do have some people who may be at higher risk that may need a second bivalent dose. And so for those people, up to date would include that second dose. But currently in NHSN, it's basing it on having 1 bivalent vaccine. So as you're looking at that up-to-date status for your residents or for your staff, that's what it should be based on. In their latest update, I don't know if I can grab it quick enough. There's a great algorithm that just shows how to decide if someone's up to date for NHSN decision making and entering that data. I'll see if I can grab that quickly for you.
Thank you, Lori. And I see another comment in chat about concerns about having to administer 3 vaccines this fall for respiratory illness. Anyone with thoughts about how we'll manage these pending recommendations for vaccines? And I think that's a really good point. Hopefully we can just be able to administer all 3 of them together. Of course, we haven't seen if that's going to be something that's recommended yet with just the approval of the RSV. I'm sure they are going to be looking at making sure that they can be administered together. But anyone else who has thoughts on that, feel free to chime in.
The nice thing is that there's the mobile vaccine clinics, both in Montana and Wyoming that we've partnered with. That would be a nice way to be able to possibly set up waves of vaccine clinics where if you cannot get them all at the same time, you could maybe have, week after week after week or whatever it is, but you can just be in contact with the Farm 409. That's correct, right? Farm 409, Kyla?
I think it's Farm 406.
Farm 406, yeah.
Yeah.
Sorry. Jesse's not on. She's the guru in this stuff. But I mean, you can always think about, the mobile clinics in your area that, so you're not having to actually stock the vaccine itself and then try and figure out that timing, or, when we get guidance, but there are other options besides just having all of the medication at the facility and then having the immunizations given.
So I see another comment in memory care units. Oh, it just scrolled up for me there. In memory care units, they tend not to have alcohol-based sanitizers in site as a safety issue. Residents may attempt to take them or misuse, so they often have hand wipes for the memory care residents. Any comments on that, Anna, or anybody else?
Yeah, I think Lori's comments about doing a risk assessment are super important. There are some observations in here that, SHEA recommends that there aren't non-inferiority studies available on hand wipes for the healthcare provider. So they don't want to recommend that as an option for the healthcare provider, but potentially having, something different on your memory care units, like more tamper-proof options, or having healthcare providers carry their own hand sanitizer, figuring out what works for you. But I've heard that. I think it's a growing area, and I'm sure that there will be more products on the market, available for this particular problem in the future.
Thank you, Anna. And thank you everyone for joining us today. We will meet again next week on May 17th, same time. And I hope everyone has a good rest of your week.